Like you guys don't play those. And there's some good stuff. I'm so scared. You obviously the last time that we the go to like house of wisdom study. That was like the day. Which you pay the registration. You pay 50 for study. Try to work on the yeah. Yeah. This is not history.
Very good morning, everyone. Today, I want to welcome all of you for the second day of the Emirates Pathology, Digital Pathology, Cancer and Gastroenterology Conference. Myself, Dr. Jaya Jain, I have the pleasure today to be the chairing the first session of this conference. Yesterday, we had very enlightening and engaging session regarding digital pathology, pathology in general, and also the gastroenterology. Today, I am also looking forward to have enlightening experience and learning from all of you and to have a very engaging discussion from the audience as well. So, welcome all of you. So, we will start our day two session and I would like to introduce our first speaker, Dr. Bindu TG from India. So I would like to welcome her on the stage to give her talk on the topic True Cut Biopsy of Palpable Breast Lesion, a 10-year experience of an interventional pathologist. Over to you, Dr. Bindu. And I will also request her to give her brief introduction before the talk.
Good morning. I'm Dr. Bindu. I'm a senior consultant pathologist from southern part of India, Kerala, and I am working in the hospital. The name of the hospital is Caritas Hospital and the Institute of Health Sciences. So our hospital is a hospital with a serene background. That's India. Kerala is supposed to be the God's own country, and we have a hospital with more than 60 years of legacy, and it's more than 650 bedded hospital, and it's a Catholic Mission Trust hospital, and the current director is Father Reverend Binu Kunath. So my journey as an interventional pathologist started with a very bitter experience. And this photo is my teacher. So this was the first case encountered, and she was 62 when presented at 2014 August, and she came to our hospital and to me with a breast lump of 6 months duration. And I have done an FNA on her breast lump, and it came to be carcinoma breast. I can see the atypical cells are there, and also a cluster of large cells. So it was a carcinoma breast, and she had done the preliminary investigations, and the surgery was done. That is burst conservation surgery along with the limited axillary clearance was done, and it was a grade 2 invasive carcinoma, just T2N1 stage, and IC was done. It was triple positive, that is ER, PR, and HER2 positive. And she was planned, the cancer team, oncology team decided to go for adjuvant chemotherapy. She had an upfront surgery, then adjuvant chemotherapy. And till then, her family was taking it in a very positive way. And then the disaster started. And she, after having the first dose of chemotherapy, she developed severe drug in extravasation and ulceration. So this was the her picture of her hand at the time after first chemo. She developed severe ulceration and painful swelling, and she was screaming with pain. And when I visited her, she asked me, Bindu, you could have, if you know that they need a chemotherapy after my surgery, and this kind of complication, I could have avoided that. So, and then what happened was, then she was again taken to theater to put a chemo pot. And luckily, all the thing subsided. And after 2 years, this was the appearance. But still, you can see the thrombosed vessels and the abnormal healed area. So, she had a surgery, and then that for anesthesia was given, and then the second anesthesia for chemo pot insertion. So I was also felt guilty because this could have been avoided if that was, we know that is a cancer is triple positive, we need chemo. So that was one piece of like experience. And the second case was more tragic. Actually, this is a 32-year-old female. She was a nurse in our own institution, very bubbly girl. And she came to my OP with telling me that I'm lactating, ma'am, but I am having a breast lump. It is painful, and the surgeon want me to aspirate the material from the galactoside. So it was there for 1 month. Then I took an FNA. Mainly milk came along with some macrophages and some cells. I took it as reactive atypical cells because the cellularity was very limited. And she's 32, female, and no other history, nothing, no axillary lymph node. And she was happy. She went back, but the lump was increasing size. But she didn't notice that because she's lactating and she is busy with her work. And surgery was done after 1 year, and it was a high-grade carcinoma. And by that time, it was started investigating. It was a disseminated disease, and she died after 1 year, leaving behind a 2-year-old girl. So that was the second time I thought something has to be done, or is there any way out? Like as a pathologist, can I do something for that? Then I started thinking about performing core biopsies. So as you know, the diagnosis of breast cancer, the major 3 tests are palpation, then having palpation, and then needle aspiration or taking material from the breast lump, and also imaging. If all are malignant, coming or suspicious of malignant, you can give upfront treatment or excision accordingly. And this is the FNA or FNAC. You put a needle into the lump and take a material, and this is a microscopic appearance, and you see whether they are benign or malignant. Actually, FNAC is a time-tested test method, and it is started in 30s, and in Kerala it started in 1980s. And it is a single moderator operator model, and there's no need of any local anesthesia. That is a major advantage of having FNA doing. And even if the patient is on anticoagulant, you can go for FNA. It is not a contraindication. And for cystic lesions and for deeper lesions or skin tumors, whichever it is, size is not a barrier. Only the needle length is the problem. You can go for FNA. And axillary lymph node sampling also we can do with the FNAC. So it was supposed to be a gold standard for initial diagnosis. Then came the core needle biopsy. It started in 1990s, and but it needs local anesthesia because it's a more invasive procedure. And if the patient is on anticoagulants, you have to stop at least for 3 days. And for larger tumors, because we may go for more than one sample. And also non-palpable tumors, we have to do it under image guidance. So what's the core needle biopsy has its own specific advantage. That is, if you are in a doubt whether to differentiate between a benign and malignant lesions. I'm not elaborating all this. But core biopsy is better than a fine needle aspiration. But why core needle biopsy in carcinoma breast? That is the next question. And as you know, carcinoma breast diagnosis is not just a histopathology, but need more molecular study along with that. And the choice of treatment depends on the molecular classification of breast cancer. And there is always, especially in the recent years, neoadjuvant chemotherapy is the dictum for all carcinoma breast. And what happens is with the neoadjuvant chemotherapy, there may be a stage of complete pathological response. That means no tumor left behind, almost up to 40% of cases. So if you do a biopsy or do a histopathology examination after chemo, we will not get any material to study. And assessment of prognostic factors is possible only if you have a previous biopsy. And in a complete response, there's no chance for that. And the assessment of prognostic factors like mitosis, lymphovascular embolization, and duct carcinoma in situ. All this has to be studied in detail. And if you have a contralateral breast assessment also, then you can go for core needle biopsy. That also has an advantage. And if there is a suspicious of carcinoma, as doctor was telling, like B1, B2, these cases, we may go for incision biopsy. That was the previous rule, but that can be avoided. And also intraoperative frozen section can also be avoided if you have a preoperative diagnosis. And now it is the era of DNA and RNA studies. If you want to do a material on the archived tissue, then also we need to have tissue for the current recent studies. That also core biopsy is the answer. And if you're sure that it's a benign tumor and there's no need of surgery, then also if you have a biopsy diagnosis, we can postpone or avoid surgery. So why pathology is performing core needle biopsy? That's the next question. So palpable breast lump, as you know, it's very common, especially a country like us with the most populous country in the world. The females having palpable breast lump is very common. So in our hospital, at least 5 cases comes every week. 5 new cases come every week as a palpable breast lump. Because identification of non-palpable breast lump is very low. Because we don't have that effective screening, public screening program is not effective. And people try to avoid also. So palpable breast lump is very common. So that's why one pathologist can perform, because there is no need of having a help of radiologist. And another thing is surgeon or radiologist may disagree, but pathologists can palpate or assess the consistency better than the surgeon or radiologist, because we know in and out of the tumor, because the cut section of the tumor is identified only by pathologists. So pathologists have the more experience in assessing the consistency. And they can combine both core needle biopsy as well as FNAC. That's another advantage. And if you want to switch the program, like it was looking like a solid mass on biopsy attempt, it was prone to be cystic, you can change to FNA. That kind of switching also that possible. And for axillary lymph node, always the standard diagnostic tool is FNA. So we can do coordinated biopsy of the breast and FNA of the axillary lymph node together in the same sitting. And the most important is it's a ROSE. ROSE, the full form is rapid, as you know, it is rapid on-site evaluation. That means we have the tissue, we can assess the tissue then and there itself, in the operating room itself. Whether the cells are there, the cells are malignant or benign, that kind of assessment is only possible with the help of a pathologist, or the pathologist can do. So that is the advantage of, these are the advantages of pathologists performing core biopsies. Coming to the precautions, just I'll rush through that. And we take an informed consent, and we verbally explain the procedure to the patient. And we always ask for any history of a drug allergy, especially local anesthesia. Ask them to have light feeds and also have a responsible bystander, because the time taking, like around 30 minutes will take. And there are contraindications are there, but it's relatively rare, like blood dyscrasias. And if the patient is on antithrombotic and it cannot be stopped, or severe psychiatric illness, like a patient is 100% not cooperative. All these are the very limited contraindications. And usually, coming to the procedure part, it's usually we perform with the 14 or 16 gauge needle. It's a true cut gun. First we put a skin incision, two very small incision with the help of a very sharp edged scalpel blade. And we prefer to go for horizontal or oblique plane. And if with the attempt of core biopsy, if there is blood start coming or severe clotting is there, we stop the procedure. And after the procedure, we press the area, at least for physically, I myself press the area for 2 minutes to prevent further hematoma formation. And if you are not, as I previously said, if you want to do perform FNA, you can either do from the same incision, or maybe incision site, or maybe from the little adjacent area, because there is already local anesthesia is given now. And coming to complications, there are complications, but they're not that much. But main complication is allergy to local anesthetic. And test dose is the ideal situation, but that is not possible in all cases. So what we do is we ask for any history of drug allergy, especially local anesthesia. What I do is I ask for any history of tooth extraction, because in most of the cases, people have minimum one tooth extraction will be there. So they may have an experience with the local anesthesia. And if the hematoma formation is one complication, and a firm bandage, at least for 24 hours, can prevent the hematoma formation. And these are rare, like rib injuries and pneumothorax, but more common with the inner quadrant lesion. But horizontal direction of the lesion usually prevents that. And infection and abscess formation as rare complications. If you don't have that local cleaning is not proper, there can be, but it is very rare. So post-procedural instructions are also very important to prevent the post-procedural complications. So we put a bandage and ask them to do not disturb the bandage for a minimum of 24 hours. What we prefer to be the bandage be there for 3 days, at least 2 complete days, like it's 48 hours. We ask to remove themselves, the patient can themselves remove the bandage after 48 hours. Do not wash the area for 24 hours, and put tight garments around the clock, so that the area will remain firm. And after removal of the bandage, there can be a bluish discoloration. So we give a pre-warning that there will be some bluish discoloration will be there. Don't be panic. It will subside by its own. Never put any ointment or massage that area. That again can create problem. And avoid to don't have any strenuous exercise, like vigorous home work should be prevented. And we give the report within 5 days. And we'll ask them to come on the 5th day, so that I myself can examine the patient to assess the local area, and also we'll give the report in hand. And ask them to report if there are pain or swelling or breathlessness. It's a rare incidence of chemotherapy or pneumothorax or rib pain, poking into the rib can occur, but so we warned them before. And all these put together, we have a leaflet. We have printed leaflet. It's bilingual, both English and in our local language, and that is gradually provided to the bystander. Ask them to read carefully from the hospital itself, and if there is any doubt, they can contact. We'll give our lab number also. So coming to the pathologist main role, gross examination part. I usually take minimum 4 core, each of 1 centimeter long. So this is the appearance of cores. And if their cores are very small, I try to take more. But most of the time, 3 or 4 core will be enough. And if the abnormal tissue usually have a white or gray white appearance, and it's usually firm in consistency, it sink to the bottom of the container. And so this is something like this. So it will go to the bottom of the container because of the consistency. And the necrotic tissue will be usually friable, and it may shatter into small pieces. And yellow tissue, as you know, it will be yellow will be fat tissue. It will float on the surface, on the saline surface. So initially I put the material in saline, then I transfer to the formalin. That's my way of doing, because you cannot if you multiple dip into the container may actually harm the patient with some kind of formalin contamination, like formalin toxicity. And another interesting finding I have found is this. I think you can appreciate that a thin string with bead appearance. That is actually it's in favor of a benign tumor, a benign breast tissue. So these are some better tips to get better specimen. A maximum diameter is the ideal way to get the maximum core. If the first tissue is necrotic, you can change the angle to the periphery, because most of the time the tumor, the center part will be necrotic. And immerse the needle tip in a sterile bottle with the saline, so that the tissue will be taken by its own into the saline. Not try to remove with the forceps or scalpel or needle. That will actually crush the tissue. And if there's a mucinous material, you may not get a full core. Then you have to do a FNA and cell block. That will yield better tissue. And maximum 4 to 6 core. Make 3 or 4 wax blocks can be made on that. So these are just photographs of different stages of doing the this thing. And here you can see you can actually float into the tissue is floating into the it is passing into the saline. And I use 14 gauge as well as 16 gauge. But as you can see the sections are more thicker and more firmer in 14 gauge. So if the tissue is biopsy, so the breast lump is too small, you can go for 14 or for 16, or else you can go for 14. So this, as an interventional pathologist, my personal experience is I started this journey in 2015 January. Until now, till last month, I have completed more than 2,000 core biopsy of the breast lump, both OP and IP patients. And 16 gauge needle, initially I was taking only 16 gauge, now 14 gauge is also taking. And till now we had only 3 complications, that is persisting pain after 2 days. And we managed with the painkillers, that's all. Nothing, no local problem was there. And no major complications till now. And it actually, I started as a correlation study. That is FNAC, coronary biopsy, and the same patient's excision biopsy. These 3 together. So that was my initial study. And actually, I presented this paper in my in the United States Canada Pathology Association annual meeting in 2019. So now we are I'm doing coronary biopsy from other side, palpable, like soft tissue masses and all. And head and neck, I usually don't touch, because as you know, it's a very cellular vascular area. So this current series, I am presenting now, it is 877 cases, and the inclusion criteria is BIRATS 4 and 5, and both true cut biopsy and excision done in the same center. That's our center itself. All are primary resections before chemotherapy. All that cases only I included in this group in study. And this is the distribution of cases. You can see it has a very high positive value. It is true positive is 94%. And it has a very high sensitivity and specificity. And positive predictive value is 99.6%. So core biopsy is a very good procedure for diagnosing breast cancer. So to conclude, true cut biopsy is better procedure than FNA for palpable breast lump. Not only palpable, because I am more into that. That's why I am telling. Now I am doing guided also with the help of our intervention radiologist team. Complications are similar for both FNA and core biopsy. The complications are similar. And the pathologist's advantage is that they get to know about the patient. We can get the details from the patient directly. And we can get even a rapport of the patient we'll get, and all the follow-up will be easy for us. And the most important thing is, as I told earlier, a rapid on-site evaluation. That is only possible with the pathologist. That is a major advantage of pathologist performing the procedure. Thank you. Any question, doubts?
Thank you, Dr. Bindu, for walking us through a very important topic of true cut biopsy of breast lump. And I have a question for you. As you mentioned that you are doing ROSE, rapid on-site evaluation. So have you done any concordance study between the ROSE result and the result after the complete histopathological examination?
Yeah. Actually, we do ROSE not only for my cases, for in doubtful cases from IR suite room, that intervention radiology room also they come for core by ROSE evaluation, but not that this is almost 100% previously, but now it is in doubtful cases. But for doubtful cases, our biopsy histopathology correlation is the similar, like more than 95% correlation is there.
Thank you. And I also want to congratulate for doing a pathbreaking thing for a pathologist. Like usually pathologists don't do the true cut biopsy. It is either surgeons or radiologists, but you are starting to do this thing so that pathologists are also part of the clinical setup for the patient for caregiving.
Yeah. Actually, pathology is a clinical specialty.
Yeah.
In India, it is now redesignated as a clinical specialty. We are very happy about that. So we are no more behind the screen. We are behind the curtain. We are in the center stage now. Thank you.
Any questions from the audience?
As from a breast pathologist from US. Sir, anything to comment? I can't hear you properly.
So I'm saying that in the interventional radiologists, they take the biopsy and at the same time they'll deploy a metal clip. So once, if it is diagnosed as malignant, the surgeon will know the area to go to, and they're intraoperatively, they'll take that lumpectomy out and x-ray it. So I just think it's very interesting the pathologists are doing this.
Yeah, that's how applicable to less than 1 centimeter, very small size, non-palpable breast lumps. But in our country, we are not that much developed because every day we are getting all the palpable breast lumps are there, not in many numbers. Thank you.
Thank you.
Dr. Bindu, I would like to give you the certificate for your wonderful presentation. Now I would like to call upon stage Dr. Zubeda Rasool. She is a professor of pathology in Sher Kashmir Institute of Medical Science, Srinagar, India. And she will be giving a talk on topic immunohistochemical profile of extrahepatic biliary atresia, a case series of rare biliary tract disease. Over to you, Dr. Zubeda. Please give a brief introduction of yourself.
Good morning, everyone. I am Dr. Zubaida Rasool, uh, acting as a professor in the GI division of histopathology at Sher Kashmir Institute of Medical Sciences, India. Yeah, it has been 15 years of my experience in GI division. So today I'm going to talk about my experience in the immunohistochemical profile of extrahepatic biliary atresia. It's a case series of 11 cases for 2 years. So, coming to the introduction, that as you know, biliary atresia is a rare disease of exclusively neonatal period. It's characterized by biliary obstruction of unknown origin, resulting in progressive fibrosis and obliteration of extrahepatic and intrahepatic bile ducts. It occurs in 1 per 10,000 to 16,700 births, with a slight predominance in females. Its frequency is higher in East Asian countries, including India, comprising one-third of neonatal cholestasis. The affected children show progressive liver disease with development of portal hypertension and liver failure, resulting in death within first 2 years of life. Biliary atresia remains the most common indication of liver transplant in young children. It is the most common surgical cause of neonatal cholestasis, and Kasai procedure remains the only treatment that can be offered to these patients besides liver transplant. So in our part, usually Kasai procedure is being done because being the country with resource limited sources, so we can go for Kasai procedure only most of the times. So latestly, the etiopathogenesis about the biliary atresia, it has been found in murine, and human studies have suggested that viral infections like reovirus, rotavirus, cytomegalovirus, and Epstein-Barr viruses, they are important causes of this biliary atresia. And environmental exposures like biliary toxin, biliatrazone has been seen, and other developmental defects like biliary atresia susceptible gene has been found in the patients of biliary atresia, and abnormal fibrogenesis has been one of the causes. Also, genetic predisposition with GPC1, ADD3, and ADP ribosylation factor has also been found to be its cause. Another, it has been said that aberrant, although the cause is unknown, but these are the hypotheses and murine models which have been shown to be the probable causes for biliary atresia. Aberrant neonatal immune responses causing autoimmunity are one of the important, most recently and widely accepted trigger. Among these are HLE genes, which are linked to various autoimmune disorders, and it has been seen the patients with biliary atresia in the longer life, they develop various autoimmune diseases. So immune dysregulation, for example, decreased TREG subset of CD4 function has also been seen associated with biliary atresia. So, giving a brief description, what are the different types of biliary atresia? It has usually three types. They have been recognized as type 1, which is common in only type 1 is present when there is atresia in common bile duct only, and type 2, only common hepatic duct is affected. And in the type 2B, common hepatic duct, cystic duct, and common bile duct is affected. And type 3, right and left hepatic ducts, common hepatic duct, cystic duct, and common bile duct is affected. That means whole of the ductular area is affected in type 3. Now, the aim of my study was to diagnose the cases of biliary atresia by histopathological examination and to confirm the diagnosis by immunohistochemical stains and then correlate the biliary atresia with the clinical presentation. It was a retrospective observational study for 2 years from June 21 to 23, and I could find 11 cases. And the present place was the Sher Kashmir Institute of Medical Sciences, India. My study included a wedge as well as core biopsies sent after surgical procedure of Kasai procedure. Only 2 cases were diagnosed as biliary atresia preoperatively on HIDA scan. Rest we have diagnosed. It was only the clinical suspicion. The patients underwent Kasai procedure and we did the histopathology. Rest of the cases were operated on clinical suspicion and relevant clinical and radiological findings. And on histopathology and immunohistochemistry, we confirmed the diagnosis. All the 11 surgical biopsy specimens were fixed in buffered formalin and embedded in paraffin blocks. After tissue processing, routine staining with H&E was performed, and then fibrosis score was done by special stains like Meisson's trichome stain and reticulin stain. Unstained slides were also examined by means of immunohistochemistry using mouse anti-human antibodies for cytokeratins like CK7, CK19, and CD56, which are used to outline bile ducts and ductular reaction and duct plate malformation. A total of 11 cases were analyzed in our study in 2 years, and out of which 6 cases were males and 5 were the females. 10 cases were in the age group of 1 to 2.5 months, and while only 1 case was about 23 months of age, and ductal plate malformation was seen in 2 patients. So, coming to the clinical presentation or clinical features of the patients, most of them were the females, and jaundice was one most important clinical presentation, and dark urine, and obviously acolic stools were there, and hemoglobin was normal, and TLC was also normal in all the patients. Then about the KFT and LFT, almost KFT was normal, but bilirubin, total bilirubin was very much raised, and most of the transaminases were raised, and GGT and ALP was also seen to be raised in most of the cases because of the cholestasis. So our observations, we concluded all the patients typically present with total bilirubin levels higher than 5.6 milligrams per liter, and GGT levels were higher than 100 units. AST and ALT levels were also between 80 to 200. In addition, other liver enzymes were also deranged, which I also already demonstrated on the slides. And these some cases were showing increased normal, a few cases were showing normal enzyme levels, and few cases were showing raised enzyme levels, which was very less. So, coming to the results, the key histological findings for the diagnosis of biliary atresia in all 11 cases revealed bile duct proliferation, bile ductular reaction, along with portal fibrosis as well as breaching fibrosis. Similarly, portal edema, ductal bile plugs were also noted, suggesting them to be the independent histological predictors of biliary atresia. Portal duct proliferation, bile stasis, and portal fibrosis are important indicators and independent prognostic factors for biliary atresia. Immunohistochemical reactions by CK7 and CK9 along with CD56 outlined immature bile structures, which are very helpful for the diagnosis of biliary atresia. Our study revealed ductular reaction and duct plate malformation by immunohistochemical staining positivity with CK7 and CK19 and CD56. This ductular proliferation is demonstrated by CK7, which reacts with biliary epithelial cells but also with the progenital hepatocytes. So coming to the slides, H&E stain of the biliary atresia, it shows there is the ductular proliferation. You can see these are the ducts, there is diffuse ductular proliferation, there is fibrosis, and you can see on high power, we can find the ductular proliferation. These are the bile plugs. These are the rosettes with bile plugs within the canaliculae. Giant cells are also formed here, a little bit of hemorrhage and fibrosis, which is well demonstrated on spatial stains, Messon's trichome stain. So this bluish discoloration, this shows the fibrosis. The fibrosis is going beyond the portal areas, bluish, with cholestasis within the hepatocytes and ductular proliferation. On high power, you can nicely see the fibrosis, bluish fibers, and these are the this is the ductular proliferation, how many ducts are there, and bile plugs also. This is a cellular as well as canalicular cholestasis, and in fact, also giant cell formation at places. Coming to the immunohistochemical stains, PD56, which is stained by these ducts, you can find, and these are the hepatocytes which have not been stained, and these ducts have been stained. This is the high power IHC staining of these ducts. So this is very important. CD56, it doesn't stain normally the biliary epithelial cells, normally immature biliary ducts, biliary epithelial cells, it stains. Also CK7, you can find CK7, these ducts low power, these ducts with almost don't have these lumen. They are stained by the CK7, and this is the fibrosis. These are the small ducts that shows that there has been ductular proliferation. Normally, there is no ductular proliferation in the liver. So in biliary atresia, I can find this. Another IHC marker CK7-19. It's positive in all the stages. Ductular stage, remodeling stage, and remodel stage. So these are all ducts. Normally, cannot find this. So these are the ducts, immature biliary epithelial cells. This is the low power. This is the high power. For the control, I have put CK20 also, which is negative in these ducts. You cannot find any of the ducts positive on CK20. So this is the low power and this is the high power of the same. So coming to the results, the reaction with CD56 allows one to identify immature biliary epithelial cell and determine that in the presence of ductal plate malformation. The presence of CK7 and CD56 positivity can be a sign of newly formed bile structures and often shows no lumen, suggesting inhibition of the maturation process in biliary atresia. CK19 positivity occurs in all three stages: ductal plate stage, remodeling, and remodel stage of ductal proliferation. These are the immunohistochemical results. I found ductal proliferation is present in almost all cases. Bile plugs are also found in almost all cases. Rosette formation was also seen. Rosette formation is usually seen in the cholestasis diseases of liver, and giant cell formation was present also in most of the cases. Extramedullary hematopoiesis are rarely seen in most of the cases, and ductular proliferation. So to differentiate ductular proliferation from ductal plate malformation, only 2 cases of ductal plate malformation were present in our cases, 11 cases out of 11, only 2. So that was differentiated by CD56. 3 cases came positive on CD56, 2 cases, CD56 rest. None of the case was positive on 56 when there was no ductal plate malformation. And fibrosis, obviously, we have graded fibrosis, grade 1, 2, and 3 in 3 cases. In one of the cases, there was bridging fibrosis, which I have graded as grade 3. So, liver biopsy interpretations in biliary atresia is challenging to discern as the histopathological features of bile plugs in portal ducts, ductules, portal edema, and higher grade subportal fibrosis are often non-specific and may overlap with other liver conditions, making definitive diagnosis challenging. These features in presence of ductal plate malformation are helpful in biliary atresia, in differentiating biliary atresia from non-biliary atresia cholestasis. In biliary atresia, lack of remodeling results in ductal plate malformation. Ductal plate malformation is found in almost 20% of the biliary atresia cases. In this study, ductal plate malformation was present in 2 cases only. And CK7 and CD56 are very helpful to diagnose the immature bile structures. The acute stage of regeneration is usually characterized by the proliferation of duct, and chronic stage is characterized by proliferation and metaplastic transformation of hepatocytes into metaplastic bile ducts. Ductal proliferation is demonstrated by CK7, which is positive in biliary epithelial cells and progenital hepatocytes. But CD56 demonstrates immature biliary epithelial cells and which can determine DPM. CD56 expression is higher in DPM compared to those of neonatal hepatitis and choledochal cysts, where you can also have, child can have cholestasis. CK7 and CD56 positivity can be a sign of newly formed bile structures and often shows no lumen, suggesting that maturation process has inhibited, which occurs in biliary atresia. CK7 expression begins in remodeling stage and is characteristic feature in remodeled stage. CK19 positivity occurs in all the 3 stages: remodeling stage, ductal plate stage, remodeling stage, and remodeled stage. There are 3 stages of duct formation. CD56 expression is characteristic for remodeling stage. The presence of CD56 positivity also implies that biliary atresia is progressing to liver fibrosis. So all cases in our study had portal, periportal fibrosis and portal to portal fibrosis without cirrhotic change. None of the cases was having cirrhosis, fully developed cirrhosis. And the differential diagnosis of the biliary atresia with other forms of infantile cholestasis is often difficult, which I already expressed. However, immunohistochemical positivity for CD56 is helpful in the differential diagnosis, as the expression of immature bile duct occurs in biliary atresia, but not in patients with neonatal hepatitis. So we can conclude that biliary atresia is a multifactorial disorder with varied outcome. From a pathological perspective, recognition of unequivocal biliary obstructive features is essential for accurate assessment and needs to be distinguished from neonatal giant cell hepatitis as being its closer differential diagnosis. Prenatal screening, identification, and early detection after birth depends on advanced imaging techniques, biomarker analysis, genetic testing, and timely clinical assessments to ensure early intervention and improve outcomes. In addition, IHC methods by using CK7, CK19, and CD56 are useful in the diagnosis of biliary atresia in determining the stage of developing bile duct cells according to the expression pattern. Thank you for patient hearing. Any questions?
Thank you, Dr. Zubeda, for your detailed talk on liver biopsy in case of biliary atresia. So I have a question. Which grading you have used for fibrosis in your study?
I have used Ludwig's staging for liver fibrosis. Yes.
Thank you. Any questions from the audience?
Very nice presentation, Professor.
Thank you.
And my doubt is, do you do IHC for all cases of biliary atresia, like only neonatal with
Usually neonatal hepatitis they don't do. We don't go for biopsy. But if the clinician has some doubt after, then they go for this Kasai procedure, and then we get the veg biopsies Then on those cases, if I feel that I'm the hepatopathologist there, if I feel, and I am a junior, if I feel that it needs some confirmation biopsy, routinely we don't go for, but in some special cases we go for.
Yeah. It's a new information we also try to incorporate in our hospitals.
Thank you.
Thank you.
I now would like to present the certificate for our speaker, Dr. Zubaida. Poster presentation from our group of young attendees, I would like to invite Miss Ludmila Lal, Miss Wasima Siddiqui, Miss Rhea Jane Pinto, Miss Jaren Tasmin, and Miss Sadia Khan to come and present this study on the title Prevalence and Prediction of Acne Among Adolescents in the UAE, a cross-section study. Please also introduce yourselves.
Good morning, ladies and gentlemen. We are delighted to present our research titled Prevalence and Predictors of Acne Among the Adolescents in the UAE. Our research group comprises of myself, Ria Jean, Jareen Tasmin, Shamina Yasmin, Basima Siddiqa, and Ludmila Lol. And we're from the College of Medicine from the Gulf Medical University. How many of us remember struggling from acne as a teenager, or perhaps we still do? Acne vulgaris is more than just a teenage problem. It is one of the most common dermatological conditions affecting millions globally, and its impact goes beyond the skin. For many adolescents, acne can significantly affect self-esteem, confidence, and mental health, and their overall quality of life. The pathogenesis of acne is multifaceted, and this research sheds light on the interplay of biological, environmental, and physiological and psychological factors. Despite being so widespread in the UAE, there has been limited research exploring these factors influencing acne, and that's exactly where our study comes in. The study holds potential for refining prevention strategies as well as personalizing treatments to improve outcomes of those affected. Just to mention our objective, it is to assess the prevalence, predictors, as well as the psychological impact of acne among the adolescents aged 10 to 19 years in the UAE.
So I'll be taking you through the methods we used to conduct our study. So we used a cross-sectional design for the study, which was ideal for assessing the prevalence of acne and its associated factors within a specific population, and the association between multiple variables such as socio-demographic characteristics, lifestyle factors, and the severity of the acne. A total of 374 adolescents aged 10 to 19 years in the UAE, mainly from schools from Dubai, Sharjah, and Ajman participated in our study. Both male and female students of all nationalities were included to reflect the diversity of the UAE adolescent population. The age range was selected because adolescence is the period where acne prevalence peaked due to hormonal changes. Data was collected using a self-administered questionnaire distributed to students who met the inclusion criteria. The questionnaire captured information in 4 key areas. Firstly, socio-demographic details such as age, gender, family history, and the skin types, followed by acne prevalence and severity. So the frequency, severity, and treatment of acne, and followed by dietary habits and lifestyle questions were also asked. And the psychological impact was measured using the General Health Questionnaire GHQ28. And after data collection, the responses were analyzed using SPSS version 26, and we applied 3 key statistical methods. Firstly, we used descriptive statistics to summarize the demographic characteristic of the participants and acne prevalence rates, followed by to explore the associations between variables. We used the chi-square test. This helped us identify significant relationships, such as the link between acne prevalence and its dietary habits. Finally, we perform logistic regression analysis. This is to identify the predictors of acne, such as family history and age, while controlling for other variables. And this methodology ensured reliable findings that contributed to our understanding of prevalence of acne, predictors, and its psychological impact among adolescents in the UAE. And
Okay, so I will be speaking about the prevalence of acne among adolescents. So acne is a significant concern with an overall prevalence of 64.5%, as you can see in the pie chart, among the adolescents we surveyed. This highlights just how widespread this condition is among this population. When we look at the gender-specific data, females show a higher prevalence of acne with a 69.7% compared to 61% in males. This gender disparity may be influenced by hormonal differences, skincare habits, or other factors that are unique to females. Age also plays a significant role, with acne becoming more prevalent as adolescents grow older. Among these age of 14 years or younger, the prevalence was 52.8%, and for those aged 17 years and older, this increases, the prevalence increases to a 76.3, which is very significant. This trend suggests that the hormonal changes during late adolescence may be a key factor driving acne prevalence. To provide a clearer understanding of these findings, we have included a table 1 and table 2, which visually represent the prevalence rates across various socio-demographic groups. These visuals demonstrate the progression of acne with age and its difference by gender. Okay, so the socio-demographic factors, table 1, the sample included 373 participants with a slight majority of females, up to 53.9% over males, which was 46.1%. A large proportion of parents had higher education level, with 63.9 of fathers and 55.1 of mothers holding qualifications above college level. Family history of acne, 37.7% of participants reported a family history of acne, emphasizing its genetic component, while 41.4 were unsure about their family history. So the p-value of our survey was 0.081. This indicates that the difference in acne prevalence between males and females is not statistically significant. These findings underscore the importance of targeted interventions, particularly for older adolescents and females who appear to bear the brunt of this condition.
Moving on to more key findings of our research, I will be specifically focusing on the significant predictors of acne. One of the strongest predictors that we found was family history. Adolescents with a positive family history of acne were significantly more likely to develop the disorder themselves. The finding highlights the role of genetics in acne development. This could also be due to hereditary factors such as skin type, hormonal patterns, or oil gland activity. Understanding this association can help us implement early intervention as well as educating families on managing acne proactively. We also initially observed that oily skin type as well as the consumption of high glycemic index foods was statistically significant with acne. However, after applying logistic regression as well as calculating both the adjusted odds ratio as well as the crude odds ratio, these associations were not found to be significant statistically.
Good morning. My name is Ludmila Lol, and today I will be presenting findings on the association between acne severity and overall psychological distress assessed using the General Health Questionnaire 28. Acne vulgaris is not only a common dermatological condition, but also one that can significantly impact an individual's mental health and quality of life, particularly in adolescents and young adults. Psychological distress, including anxiety, depression, and social withdrawal, has been linked to acne severity. Our study aimed to examine the relationship between acne severity and psychological distress as categorized by the General Health Questionnaire 28 tool. Participants were categorized based on the severity of acne into following groups: no acne, moderately severe acne, and severe acne. The General Health Questionnaire 28 was used to assess psychological well-being, with participants classified as yes, indicating distress, or no, indicating no distress. Statistical analysis was performed, and p-value of 0.046 was obtained, highlighting a potential association. Now let's look at the key findings. In the no acne group, 49.2% reported distress, while 50.8% did not. In mild acne group, 52.5% reported distress and 47.5% did not. In moderate acne group, distress increased to 63.8%, while 36.2% did not report distress. Moderately severe acne group, a notable 74.1% reported distress and only 25.9% did not. In severe acne group, similarly, 71.4% reported distress, while only 28.6% did not. From these findings, we observe a trend. As the severity of acne increases, the proportion of participants experiencing psychological distress also increases. The p-value of 0.046 suggests that the relationship between acne severity and psychological distress is statistically significant, highlighting an important association. This result underscores, This result underscores that individuals with moderate to severe acne are at a higher risk of experiencing psychological distress. It also suggests that clinicians and dermatologists should not only focus on the physical treatment of acne, but also consider the psychological burden it imposes on patients. In conclusion, our study demonstrates a significant association between acne severity and psychological distress as measured by GHQ-28. These findings highlight the need for multidisciplinary management of acne, incorporating both dermatological and psychological interventions. Thank you.
Okay. So acne is highly prevalent among adolescents in the UAE, with age and family history identified as the significant predictors. Older adolescents and those with a family history were more likely to be affected. Moderate to severe acne was also linked to increased psychological distress. These findings highlight the need for targeted public health interventions focusing on education, effective skincare, and psychosocial support. However, the study's cross-sectional design and self-reported data warrant further research using longitudinal approaches to validate these results and explore factors like stress and environmental influences. Thank you very much.
Yes, this concludes our research presentation.
Thank you for your wonderful presentation. So I have few questions. So one of the questions for grading of acne, how have you graded the acne into different grade? What was the criteria used for grading the acne into mild, moderate, and severe?
So yeah, we use the description. So it's actually a WHO classification of these five, and we added a description to each category, and it was students who were given this questionnaire who chose their category. Yeah.
Okay. And another question is like you have mentioned in your study that you have also studied the dietary habit related to acne. So in the results, can you show some light on how the dietary factor affect the acne?
Uh, yeah. So as we mentioned on our first analysis, high glycemic index foods. So we were talking about sugary foods, all those junk foods, which we had explained to the students if they, and based on their consumption, we had found them to be statistically significant. And in comparison to the others, after applying logistic regression, they were not statistically significant, but they do, raise a question that they might that high glycemic index foods might have an involvement in the prevalence of acne.
Thank you.
So what we did, we asked them about the frequency of the intake per week. So let's say they eat high glycemic foods every day, or they eat it twice weekly, etc. And we categorized these according to that.
Thank you.
A nice presentation. And do you have, because you have delineated a group, do you have a follow-up or giving advice, general advice like modification or dietary habit, that kind of thing is there, or just a statistical analysis?
For now, I think it's just a statistical analysis, but definitely, given that we were talking about how family history includes, so there are specific uh, interventions that you can do based on moisturizers, face washes that help for specific skin types. Again, as we said, oily skin type did have statistical significance. So based on that, it would help, but as of now, it's just this.
Thank you.
Any questions from the audience? So we will proceed with the certificate. So I would like to call Miss Rhea G. to receive the certificate. Miss Ludmila Lal for certificate. Now, I would like to call Miss Wasima Siddiqui to receive the certificate. Now, I would like to call Miss Zareen Tasmin to receive the certificate. I would like to call Ms. Sadia Khan to receive the certificate.
Can you take me as well? No, can get a group one, please? I do. Yeah.
Looking forward to our next poster presentation. I would like to call moving forward. Now I would like to call Ms. Mara Miyagi, Mr. Mustafa Al Hamadari, Mr. Marwa Nasir, Mr. Mustafa Muhammad Iqbal to present their poster on the topic The Barrier of Prenatal Care in Mannerism. Please also introduce yourselves.
Hi, good morning, everyone. I'm Maram, and this is Mustafa, and this is Mujtaba. Today, we're going to be presenting our research, which is on the barriers to prenatal care in the MENA region. Thank you for attending.
Okay, so good morning, everyone. So today we'll be discussing the barriers of prenatal care and antenatal care. This ties into compliance and attendance. So here we'd like to prevent problems from happening before them happening in terms of a pathological point of view. So here, in terms of the MENA region, women face many problems that can prevent them from attending care. It can be due to many factors, and this can lead to many problems such as high blood pressure, anemia, gestational trophoblastic diseases, choriocarcinomas. It can also cause anemias, and as a result, studying these factors can be very important to prevent these conditions. So when it comes to the MENA region, women usually have lower attendance in care. This can be due to different parts of the MENA region. As we know, we have the Gulf regions, we have Egypt, Yemen, Syria, places of conflict. So as a result, we'll be studying the geographic, demographic, socioeconomic, cultural, psychological, and systematic factors. So in terms of the background of this study, so maternal care and antenatal services are essential in promoting health in pregnancy and preventing complications. This can tie into early prevention and monitoring of the condition of the mother. The most common conditions that can happen due to a lack of antenatal care, as I mentioned, are hypertensive diseases, gestational diabetes, anemia, and as a result can cause intrauterine growth restrictions. Without proper care, women are at a higher risk of adverse problems such as postpartum hemorrhage, near miss pregnancies, and as a result, lower maternal health and neonatal health. So, as a result, inadequate care can be caused by many factors. It can be prevented by many factors, and it can also be caused by health education, particularly in underserved areas, which make up a big chunk of the MENA region, unfortunately. This is caused by poor mental health and poor mental health access, and it can also cause by lack of awareness and long-term complications. So, for example, children born to mothers with poorly managed pregnancies may face higher risk of developmental delays and chronic conditions later in life. Improving these care can address the social cultural barriers and essential for reducing maternal and neonatal morbidity. So, in terms of our objectives, we'll be just assessing the. We can't see that. Sorry. Okay, so in terms of, it goes in. Yeah. So our objectives will be to identify the barriers preventing pregnant women from receiving prenatal care in the MENA region. We will also be able to understand the association between the demographic factor profile of patients, as well as the socioeconomic factors, their residence, where they live, their family size, and other variables. We will also be assessing the knowledge of receiving care in the MENA region amongst mother and their families. And we'll be also studying the impact of prenatal care on healthy babies and mothers postpartum. We'll also be investigating the prenatal interventions that are currently in place in the MENA region, and we'll be also comparing it to the European standards as well as the American standards. Now, in regards to the methods, essentially what we've done is that we've gathered a bunch of articles. We essentially gathered 800 or so articles, excluding those ones that were case studies, as well as case series, systematic reviews, and other meta-analysis. Essentially, from the inclusion criteria, we've mainly included cohort studies as well as case control studies, and we've looked at and made it more focused within the last 10 years. Now we've used certain tags or certain databases like WebMD, for example, and we use certain tags like prenatal antenatal care, or for example, maternal mortality anomaly testing, as well as obstetric or gynecology care. And essentially, we're looking at different regions, like Yemen, Palestine, places like Iraq or Iran, and looked at essentially how they've conducted or how the studies have shown that they've conducted their own antenatal or prenatal care in those areas. Finally, after that, we've then gathered all of this information, and then we've made specific domains specifically for the results. Now, the domains that we've found to be very similar are things like socioeconomic status, things like the healthcare system, or even the type of database that they would use to record these healthcare systems, things like the political factors, or maybe if it's a place that has war, or if there is some form of shortages, for example, places like Palestine, places like Yemen, places like even in places like Iraq, for example, they would have a lot of shortages, so the resources would be quite difficult to find. So that could be another factor within. Also, psychological factors. We found a lot of women to have distress because of the area that they lived in, or because, for example, it was quite difficult or arduous to travel, or their home statuses as another reason to why they couldn't find or didn't have adequate care. And so these domains will be taken and then will be compared from different regions. Areas that were better or had better research, we found was places like Iran or Iraq, as well as places like Egypt. But places that we felt needed more of or better research was places like Palestine, for example, or Yemen. Yeah. Okay. So as per our study, our findings, I'll be comparing it to the European findings. So in terms of demographic and socioeconomic barriers, in the MENA regions, education and age and employment status were also highly correlated to antenatal care attendance. So for example, in countries like Egypt, Jordan, Iran, Morocco, Saudi Arabia, and Lebanon, women between the ages of 20 to 30 had higher education and secondary school, and as a result, they attended more antenatal care, and therefore they had lower risk of complications. On the other hand, older women and women who had previous uncomplicated pregnancies, as well as employed women, they thought that they don't need the care since their last pregnancy went well. So as a result, they had less attendance, and this was most common in Saudi Arabia and Lebanon, even though those countries had high services. So on the other hand, in Europe, socioeconomic and demographic barriers were manifested differently. And for example, in Norway, 46.1% of migrant women reported that they were struggling to navigate the healthcare system itself. The healthcare system was really good, but they just were not able to work their way around it. And as a result, 63.3% of the studied women believed that antenatal care would be more accessible if it was in their own language. So the biggest problem in Europe is that they have good care. It's just hard to use and hard to access, although it's very good for people that are locals. And their main problem was the language barrier. On the other hand, 43% of women who migrated into Europe noticed economic constraints, and they noticed since they did not have the proper healthcare or the healthcare education and the importance of healthcare, 43% of them reported that the costs were too high for them to access. And this was most commonly in Romania. In terms of cultural barriers were the highest in the MENA region. So for example, in Saudi Arabia and Morocco, women often needed male permission to attend antenatal care. And as a result, they had less care in general. On the other hand, in Yemen and Iran, women were not able to seek antenatal care because they had the highest rates of gynecologists and obstetricians that were males. So cultural barriers played a big role. And again, with Yemen and Syria, since they're undergoing conflict and restrictions pretty often, therefore they had less healthcare systems in general because most of them were undergoing very big restraints and very big stress. So most women just remained home and were not able to access antenatal care, and therefore they had to go through lesser quality antenatal care. So, and as a result, they were not even able to travel to their care facilities. On the other hand, in Europe, cultural restrictions were less prevalent. It was mostly due to psychosocial barriers. And this was most commonly in Sweden and Norway, where stereotyping was pretty common and fear of judgment amongst migrant women again. And as a result, ethnic disparities in UK delayed the antenatal care initiation to begin with. So for example, Black African mothers, they experienced the highest odds of late care in comparison to white women. In terms of geographic and economic factors, MENA region, countries like Egypt, Iran, women were not able to have, it was very far for them to access the care, and they had poor transportation, and again, unaffordable costs. So for example, Afghan women in Iran reported 70.6% of unaffordable costs, 67.7% were having transportation challenges, 79.4% had long distances. In Yemen, war destroyed more than 50% of the healthcare facilities, and as a result, women did not even have healthcare. When in addition to that, they had food insecurities, and in addition, unsafe travel conditions. In Europe, migrant women, again, it was less common to have destruction of healthcare systems, therefore did not report any of those findings. And as a result of the destruction of healthcare systems, in Yemen, mortality was 7.72 per 1,000 live births, which was a big jump from their previous year. Again, I'll touch upon the COVID pandemic. It just shows that stress, any types of stress, but most notably, can cause breakdown of the antenatal care systems. So antenatal care rose from 4 to 59.5% during lockdowns. So in terms of women not receiving, so from 4% of women not receiving care, all the way to 59.5% of women not receiving care in Morocco and Jordan. And again, conflict zones, 80% of women did not receive care as a result. Again, in Europe, COVID did put a strain on it, but it was only notable in Norway and Sweden because they faced isolation. And in Egypt, home interventions were replaced. So as a result, due to COVID, 0.6% did not receive care. Now it's 59.3% that did not receive care. And complications were reduced from 38 to 15.1 as a result of improved care. And so as a result, in terms of Europe, although Europe has good healthcare systems, they had less access to the healthcare systems, mostly due to migrant women and due to disparities in cultural norms. In terms of the MENA region, it was mostly due to the gender inequalities, as well as the healthcare infrastructure and strains that can cause healthcare strain and decrease the care. Thank you so much.
So I'll be talking about comparing our results in the MENA region to America. So there are two main studies I'm going to focus on, which is one that is conducted in Florida, where it had 55 women from backgrounds, whether they're Hispanic, white, or Black. And we found that actually the reasons were similar to the MENA region, which is lack of transport, and as well as difficulty in support, lack of support, social support, whether it's their families or whether it's their husbands, as well as the fear or stigma around healthcare, because they don't want to know whether their kid has these different types of pathologies. It's better for them just not to know. And as well as problems in the healthcare system itself, whether it comes as a language barrier or there are delays in getting their appointment, or whether just the cost of getting healthcare is too expensive for them to afford. So these problems, we see that it's not just affecting one community, it's affecting multiple communities. Another study, it was conducted in North Dakota, it would focus mainly on American Indians and as well as Alaska Natives. And they found the same exact thing. There was a lack of transportation. There was problems with health insurance, so they couldn't afford getting the care that they needed. And we found that this care compared to white women was a 45% difference in the health insurance, and as well as 8.5% related to their geographic location. This is very important because what we can take away from these points is that the barriers and the quality to antenatal care, they exist everywhere. Whether it's first world countries or whether they're third world countries, there's always going to be something affecting women from going and receiving the care that they need. And these are very important because they makes serious complications not only to the mother but also to the fetal care. Like Mustafa has mentioned before, that it increases the chances of them getting gestational diabetes or hypertension, preeclampsia, or as well as maternal death and premature fetal birth. So to conclude why this is really important, I feel like together we need to address all of these issues. We need to come as a region, as a culture, to improve the transportation, reduce the stigma by educating not just the women, but as well as their families and the husbands, that needing to get these cares are very important. And it's also like our research, what we call for, we want a policy development. We want change to come within the healthcare system itself so that we can understand the challenges better in women and as well to increase the knowledge. This is really important because, like we've mentioned before about these pathological disorders that can come on the woman and on the fetus, you never know, like this fetus can be our next future pathologist or come up with a new innovative in healthcare. So it's very important to take care of every single person, no matter their background or where they come from. So thank you very much.
Thank you for this presentation and thank you for highlighting a very important importance of prenatal care in the women and the barriers. As we all know, it is a very important topic that the women receive better prenatal care and all reason, and we need to together work as a society to improve the healthcare access to all the people and to remove all these barriers. Thank you for highlighting this.
Thank you so much.
Any questions from the audience? Okay, so now I would like to call Miss Manu Miyagi to receive the certificate. Now I would like to call Mustafa Mohammed to receive the certificate. Now I would like to call Mustafa Al Humdani to receive the certificate. Moving forward, now I would like to call Ms. Alia Zuma Al Mashayaki to give a talk on the title Job-Related Stress, Resilience and Well-Being Among Nurses Working in Tertiary Hospital, Oman, a cross-sectional study. Please introduce yourself.
Assalamu alaikum. I'm Alia Jum'a al-Mashayikhi. Actually, I'm a staff nurse working in another hospital in Oman. I'm working as a nursing quality coordinator. And this is actually, it's my pleasure to present my first published research, which was about job-related stress, resilience, and well-being among the staff nurses working in tertiary hospital in Oman. So, as everybody knows, that nursing is a highly demanding and high pressure profession that lead to job-related stress, which is actually associated with physical and mental well-being of the staff nurses. And nurses and resilience, it actually refers to a person capability to adjust and bounce back from difficult situations. And those nurses who shows resilience are better equipped to handle job-related stress, maintain their well-being, which is positively impact on patients' quality of care. The main aim of the study was to assess job-related stress, resilience, and well-being of the staff nurses working in another hospital. And 3 objectives were developed to achieve the main aim of the study. The first, to ascertain the level of job-related stress, resilience, and well-being of the staff nurses working in another hospital. Determine the differences in level of job-related stress, resilience, and well-being of the staff nursing when grouped according to their socio-demographic characteristic. Third, to identify the relationship between job-related stress, resilience, and well-being of the staff nurses. And 3 research questions were developed to guide the research. First, what is the level of job-related stress, resilience, and well-being of the staff nurses working in another hospital? Second, is there a significant difference in level of job-related stress, resilience, and well-being of the staff nurses when grouped according to their social demographic characteristic? Third, is there a significant relationship between job-related stress, resilience, and well-being? And 2 null hypotheses. First, there is no significant differences in level of job-related stress, resilience, and well-being of the staff nurses when grouped according to their social demographic characteristic. Third, there is no significant relationship between job-related stress, resilience, and well-being. In literature review, stress is a major challenges for nurses, which is negatively impact in their efficiency and productivity and quality of care. And between 20 to 40% nurses globally experience job-related stress, with higher rate reported in countries like USA, 93%, and Iran, 69 to 75%. The common causes of the stress, which was due to workload, long hours, dealing with the dying patients and exposed to infectious disease, and violence from patients or family. The well-being also, it's impacted, and the nurses, chronic stress among the nurses lead to physical health issues like cardiovascular issues and headaches, and mental health issues like anxiety and depression. In resilience, nurses with high resilience are better able to cope with the stress and maintain both mental and psychological health, which is positively, as we said, it's impacting on patients' quality of care. In methodology, the study was descriptive cross-sectional study, and approval were maintained from Ministry of Health, RERAC, and from research committee from another hospital itself. And sample size were 147 nurses. Let me first to introduce to you another hospital. Another hospital is located in Muscat, capital city of Oman, and it is a tertiary hospital with several specialty in ophthalmology, head and neck, communication disorder, oral and dental and maxillofacial surgeries. And also it serves as a secondary in Muscat Governorate, providing internal medicine and pediatric. The total bed capacity is 142 beds for inpatients and 12 for daycare patients and 16 beds for accident and emergency. The inclusion criteria were Omani and non-Omani who was willing to participate. In exclusion criteria, those staff nurses who's having less than 1 year's experience, newly recruited, or those who's in training program. In study instrument, first part, it was a demographic data questionnaire. Second, perceived stress scale. Third, it was WHO 5 well-being index. Fourth, it was brief resilience scale. All of it's 5 Likert scale and free to use. In data analysis, I used SPSS software version 24, started with descriptive statistic, which is frequency, percentage, mean, and standard deviation. Second, inferential statistic, which is Kruskal-Wallis test and Spearman correlation. And the alpha level was set at 0.05 as a significant level. In a finding, 145 nurses participated in this study with a response rate of 98%. Majority of the participants were female, while only 13.1 were male. Majority of them were married, and 13.1 were single. And 29% were between age 31 to 35. Majority and non-Omani nurses were 59.3, Omani nurses were 40.7%. Majority of them had a diploma degree, while 37.9 had bachelor degree. 29% had experience of 6 to 10 years. In answering research question 1, another hospital staff nurses reported to have moderate perceived stress with mean score 22.4, which actually higher than previous study conducted also in Oman for tertiary hospitals, which is in Muscat, which was 19.2. In well-being, it shows that they have high well-being, 53.6, while when we are looking in deep, it's actually near to the borderline, with a majority of the nurses, 60.7% had low well-being. So this one give as early warning for the hospital administration to look after the causes of the low well-being of the staff nurses. And resilience, they show they have low resilience, 2.7. In answering research question 2, there is actually significant differences in level of stress and resilience according to the participant gender. It shows that female nurses had a higher stress and low resilience comparing to the male, which is actually in different studies shows different results, which is could be attributed to different cultures and factors. Also, it's worth to mention that in this study, a majority of the nurses were female who's in this study, and only 13.1 who were male, which we cannot overgeneralize the result yet. So we need a further study with a substantial number of male to participate in the study. In age, also, there is a significant difference. Those nurses with age 22 to 25 had higher stress and low resilience comparing to those staff nurses whose age more than 36. In years of experience as well, it shows those nurses with 1 to 5 years have high stress and low resilience. By this, we can say that this study found that younger nurses were more born to experience intense reaction to loss or trauma, and nurses with more experience may have better coping skills and stress management. In nationality also, we found there is a significant difference. Non-Omani nurses shows low stress and high resilience comparing to Omani nurses. This could be that in previous study was conducted and found that because of low job satisfaction and there is negative perception about their job, it's lead to have a stress. In working area, also there is, since we conducted this research in 5 departments in a hospital, female surgical ward, they showed they have low resilience comparing to others, which could be explained that different nursing tasks and working condition in a hospital department, which expose nurses to different source of stress. Although female surgical ward in our hospital, they are dealing with the less department dealing with the critical ill patients comparing to other departments which participated in this study. So we could not find a justification why those group in this department in a hospital have low resilience. So actually it's need a further study to identify the cause of low resilience. In answering last research question, we found there is a significant relationship between job-related stress resilience, which is moderate correlation, moderate negative correlation, which means by increasing level of stress, the resilience will be low and vice versa. In implications, this study addressing the job-related stress and enhancing resilience among nurses is essential for improving their well-being and quality of care. There is a clear need for targeted interventions such as stress management, training, resilience building program, and psychological support as well. Additionally, need more study in this area along with development of written policy and guideline. A limitation of the study was conducted only in 5 departments in another hospital, and random sampling and cross-sectional study only established the association between the variables without direct cause. The study relied on self-report data, which may not reflect the nurse's actual job-related stress, resilience, and well-being. Only 19 male nurses represented 13.1% of total participants, limit the generalizability of the result in comparison between the genders. In recommendation, expanding expanding the research to more than one hospital and including nurses from different specialty to generalize the research results. Nursing administration should have a policy and intervention program that reduce stress, build resilience, and improve their well-being. Nurse manager need to recognize any nurses who have high stress and low resilience. Psychological counseling should be made easily accessible and available for all nurses. And this was my references. And thank you.
Thank you for the wonderful talk. And thank you for highlighting such an important topic. Nurses are the backbone of the healthcare, and it is very important to have the to give the nurses the environment where they feel less stress, have more resilience, and their overall well-being is considered so that they can give the best care to the patient. Thank you for highlighting this for us.
Very nice topic and relevant also. And do you have developed that because you introduced yourself as the quality head of your DCT? So do you get a chance to develop a separate program to increase the resilience and to cope up with the stress? Anyway, stress is a part of nursing management.
Yes. What we are starting in our hospital nowadays, we are trying to find what is the real things causing the stress for nurses. So we are trying to find a solution to help them. We use now a technology instead of written paper because we are taking a lot of time, wasting of the time writing and despite the looking care of the patient. So we are developed things that help fast managing their time, which is also one of the things causing for stress, managing their time, and as well as we have our own program for stress management as well.
Thank you.
Now I would like to call Miss Alia to receive the certificate. So now we will be proceeding for the certificate distribution for all our participants. Thank you everyone for the patient listening and active participation. No conference is successful without the active participation of the participants, and we are really grateful for your active participation and patient listening. So I would like to call Dr. Soni Dedi to receive the certificate. Next, I would like to call Dr. Shifa Salim Al-Alawi to receive the certificate. Next, I would like to call Dr. Zainab Suilam to receive the certificate. Next, I would like to call Dr. Yusuf Al-Marzouk to receive the certificate of participation. Now, I would like to call Dr. Anas Abu Nasser to receive the certificate. I would like to call Dr. Mir Tahir Shabani Rai to receive the certificate of participation. Next, I would like to call Dr. Tayaba Khan to receive the certificate. I would like to call Dr. Yasmin Mair to receive the certificate. Next, I would like to call Mr. Jason Lau to come and receive the certificate. Next, we would like to call Dr. Ryan Al Hassan to come and receive the certificate. Next, we would like to call Dr. Rohin Mehta to come and receive the certificate. We would now like to call Dr. Safa Al Hassan to come and receive the certificate. Next, I would like to call Dr. Nada bin Madi to come and receive the certificate. Now we would like to call Dr. Neetu Elizabeth Sorge to come and receive the certificate. Now I would like to call Dr. Raha Madadi Khanan to come and receive the certificate. We would like to call Dr. Modiala Jurmi to come and receive the certificate. We would like to call Dr. Muhammad Imran Khan to come and receive the certificate. Now I would like to call upon Dr. Muhammad Mesbahuzaman to come and receive the certificate. I would like to call Dr. Moman Al Smriti to come and receive the certificate. Next, we would like to call Dr. Mayalate Heritier to come and receive the certificate. Now we would like to call Dr. Maha Al Sharif to come and receive the certificate. Next, we would like to call Dr. Farid Barakat to come and receive the certificate. Next, we would like to call upon Dr. Irini Marali to come and receive the certificate. Next, I would like to call Dr. Budur Al Shamari to come and receive the certificate. I would like to call Dr. Athira Cecil Kumar to come and receive the certificate. We would like to call Dr. Amar Al Abdali to come and receive the certificate. Next, I would like to call Dr. Amir Ashrafi to come and receive the certificate. We would like to call Dr. Ali Reza Morshim Mohammadi to come and receive the certificate. Now I would like to call Dr. Ali Hassan Alade to come and receive the certificate. Now I would like to call Ms. Dania Besela to come and receive the certificate. Next, I would like to call Professor Rola Mahmood Farid to come and receive the certificate. Next, we would like to call Dr. Elena Penchikova to come and receive the certificate. Next, we would like to call Ms. Lisa Wendles to come and receive the certificate. Next, we would like to call Dr. Alinda Madhav Sarma to come and receive the certificate. We would like to call Mr. Hossan Ahmed to come and receive the certificate. Next, we would like to call Mr. Qais Mohammed Ali Bani Hamad to come and receive the certificate. Next, we would like to call Ms. Patricia to come and receive the certificate. Next, we would like to call Ms. Saida Taki to come and receive the certificate. We would like to call Mazen Kalkau to come and receive the certificate. We would like to call Ms. Zoena Lesniak Buzon to come and receive the certificate. We would like to call Ms. Esra Musa to come and receive the certificate. We would like to call Ms. Raya Matafar Al Yusuf to come and receive the certificate. Next, we would like to call Ms. Sakina Farhat to come and receive the certificate. We would like to call Dr. Annie Soimash Gordon to come and receive the certificate. Next, we would like to call Dr. Hilarious Albert Queti to come and receive the certificate. Next, we would like to call Dr. Daniel Cubong Ivia to come and receive the certificate. I would like to call every one of you to come here for a group photo.
Thank you.
Thank you, everyone. Now we can proceed for the coffee break, and after that we can proceed to the lunch. And rest of the session will be online, and you guys can attend it from anywhere. Thank you.
You don't want to stand and teach. This way. I don't want my face to shine on everybody. And I'll take it. By your face is happy. Man, that's the problem. No, they say, you never understand. This is happening. No, it's the environment. He doesn't want to agree that my phone. iPhone is always on top. So, no, this one is the second latest of the Phantom. No, this is not Phantom. This. Come on. 30. The latest one is 30 Pro. So this is the second latest of the brand. It is just a camera quality. I think we give the best picture quality. It's the way it's the shine. The light will. Yeah, one person. Who sees it? It's almost now. And see the people. The blood pressure is good now. And yeah, like you I mean, confused. No, I'm not seeing this shit. Don't shit. So, yeah. Thank you. I appreciate it.
Hello, dear college. It's Russia.
Hi, am I audible?
Hello?
Am I audible?
Yes, I'm ready.
Okay. Very good afternoon, everyone. I am Dr. Balwant Singh Gill. Today, as the chairperson of this remarkable Emirates Pathology, Digital Pathology, Cancer and Gastroenterology Conference, humbled by the privilege of addressing such an exceptional gathering of pathology and gastroenterology professionals from around the world. It is an honor to witness the power of collaboration and knowledge sharing that this event represents. Now, I would like to call our speaker, Dr. Kevin Origa from UK. I am passing him the stage to deliver the speech on improving diagnostic accuracy in digital pathology and cancer care by integrating quality management system in cellular pathology laboratories. Please, Dr. Kevin, start your presentation. Hello.
Hello, excuse me. Do you hear me?
Yeah. Am I audible? Dr. Kevin, please check your mic. Dr. Kevin. Might be there is some network problem on Dr. Kevin. We are live. I request the Joshi ji technical team to kindly contact Dr. Kevin. Dr. Kevin, kindly remove your earbud. Kevin, kindly check your mic as well as your microphone, earphone also. Now I would like to invite our next speaker, Dr. Sviatoslav Jubak from Russia.
Hello, do you hear me?
Hello.
Хотя, смотри, вот это включили. Это? Да. Okay. Good afternoon, dear college. Do you hear me?
Yeah.
Okay,
we can
thank
hear
you. I'm start.
Yeah. You can start.
I'm pleased to present you a report of the technologies of blue plasma methylation as a method of differential diagnosis of malignant and benign ovarian tumors. Как чем? Okay. Ovarian tumors occupy the second place in the overall structure of the incidence of reproductive organs in women after neoplasm of the uterus. More than 10% of all women in the world will undergo surgical treatment during their lifetime of this pathology, the frequency of which has tripled over the past 10 years. It's good that in 18% of cases there are benign tumors. One of the problems in this insufficient accuracy of screening programs and as a result a high percentage of errors of the preoperative stage. This is evidenced by a retrospective analysis of the medical histories of patients operated on in a gynecological hospital with a diagnosis of ovarian cancer. In 34%, there was an underestimation of the stage. In 73%, there were no staining procedures. In 53%, there was no proper oblasty. As a result, during repeated surgery, 13% of patients had a residual tumor in the resected ovarian. 1 on 5 had a lesion of the second ovarian, and 1 in 4 had canceromatosis. In this regard, the golden rule, ovarian cancer is treated only by oncologists. And in order for this happen as often as possible, we have a whole landscape of diagnostics methods, the main of which are laboratory methods, ultrasound mapping, MRI with contrast enhancement. CA-122 is a gold standard for the diagnosis of serous ovarian cancer, but it has its own interference. He looked this on in my report, adenomyosis, uterine fibrosis, and others. As a result of the study, at stage 3 of cirrhosis high-grade ovarian cancer, CA-125 was normal in 12% of patients and below 115 units and a third of patients. What was he like at the first stage? We will get the answer on this question in our other observation. In our study, we analyzed the internal stages in benign ovarian tumors. In benign ovarian tumors, CA-122 was elevated in 32% of cases, and in the first stage of ovarian cancer, it was below normal in quarter of cases. Of course, the combination with CA-122 and HA4 increases the accuracy of the study, but it's approved by the FDA only for monitoring possible cancer recurrence. There are a large number of new diagnostics methods present on this slide. It's over-test 1, proteomic screening of tumor-associated antibodies, circulating tumor cells, microRNA, and serum albumin. One of which is serum albumin, which did not show again as accuracy. Over time, combined methods for calculating the risk of ovarian tumor malignancy began to appear. For example, the RMI index, which takes into account the status of menopause, the CA-122 level, and ultrasound date. Turning to ultrasound, I must say that is a wonderful method, cheap, informative in competent heads. The largest number of errors in the ultrasound diagnosis of ovarian tumors is principally due to the insufficient qualification of specialists. In this regard, it's currently MRI with contrast that is the gold standard for instrumental diagnostics with good accuracy indicators. However, due to the wonder speed introduction of MRI into the practice of private clinics, the accuracy also depends on the qualification of the radiologist. In our study, show that in benign tumors, ORADS5 was exposed in 10% of cases, and ORADS1, 2, 3, or 4 in ovarian cancer in the third of patients. Using PET-CT in the primary diagnosis of ovarian cancer has not been widely used due to the high number of false positive results, especially among premenopausal patients. The ESGO consensus adopted in algorithm for the stratification of ovarian cancer risk based on ultrasound. YOTA-ADNEX has good accuracy figures, but one should not forget about the defects in the input data caused by the low qualification of the ultrasound diagnostic and the presence of gray areas. What to do when we have high CA-122 and ORADS3, or low CA-122 and ORADS5? or when we have a suspicion of primary multiple sclerosis cancer requiring surgery for ovarian biopsy. On the other hand, the timing for treatment of already confirmed cancer. Where to perform this intervention? To solve these problems, new diagnostics methods are emerging, which includes a relatively new direction, the analysis of methylation in blood plasma. I will say in language difficult for an oncologist to hear, the name methylation consists in attaching a methyl group to cytosine in the CpG dinucleotide at the C5 position of the cytosine ring. Methylation in the promoter zone of the operon as a rule leads to the suppression of the corresponding genes. In other words, methylation is the process of regulating the activity of genes without changing the nucleotide sequence. Due to the identification of these changes, it's possible to carry out, among other things, screening of malignant tumors by blood plasma. As evidenced by the first epiprocolon test approved by the FDA for this purpose, the epigenomics test USA based on PCR-mediated quantitative determination of hypermethylation of the CpG3 site in the promoter region V2 of the SEP9 gene in cDNA from the blood plasma of patients with colorectal cancer. Modification of cfDNA methylation occur much earlier in the tumor. Methylation of cfDNA can reveal tumor traceability in primary photogy for unidentified cancer. Uniformity and stability in the tumor promises to solve the problem of heterogeneity. In the short half-life of cfDNA and the reversible nature of its methylation modification make it possible to monitor tumor progression and treatment response in real time. Publication activity has also remained at a high level in recent years, which is an indicator of relevance of the topic. Many studies show high numbers of sensitivity and specificity of plasma methylation techniques in ovarian cancer. And I'm glad to present of your attention the Russian test for the analysis of plasma methylation of ovarian target produced by SLC Biochip Russia development of the Blokhin Oncologist Research Center. The first stage was screening and testing of various gene variants and their combination. The study included 5 variants and 17 patients diagnosed with ovarian cancer. The cancer consisted of 30 health donors. There were 11 patients with stage 1-2, 52 patients with stage 3, 4 patients with stage 4, 52 patients with cirrhosis carcinoma, 18 patients with other types of tumor. The diagnosis was confirmed histologically. The analysis involves several stages. First, the routine DNA extraction. The bisulfite conversion in order to identify the target methylated sites for subsequent point detection using PCR. As a result, a test consisting of 3 genes showed optimal figures in terms of accuracy and cost in these slides, in these pictures. The next step was the accurately analyze the possibility of detecting the antenatal stages of ovarian cancer. For this purpose, 30 patients with stage 1 ovarian cancer and 30 patients with benign ovarian tumors were included in the study. According to the results, the study 89 sensitivity and 97 specificity were obtained, and in combination with MRI 98 and 99 respectively. The diagnosis was confirmed histologically. This we can talk about the board's prospect for the introduction of the methylation technologies in case of suspected ovarian cancer into clinical practice. The ovarian target DNA methylation tests show high characteristics both for the diagnosis of ovarian cancer with an already dissemination process as an alternative to interventional methods, maybe, especially in relation of patients in serious condition who are subject to chemotherapy. In combination with MRA, the tests show higher accuracy parameters in the differential diagnosis in benign and malignant solitary ovarian tumors. The use of the test for primary ovarian cancer screening rigorous in multicenter study. Potential melanoma site tests can displace CA122 from diagnostics models in the near future, despite the higher cost to date. But let's think about whether the price will be such an important role when we see these figures. The high mortality and low 5-year survival rate are associated with late diagnosis. Since more than 18% of patients were already in the late stage in the time of diagnosis. According to a number of authors, the 5 years survival rate of patients diagnosed with a stage 1 ovarian cancer is about 19% and rapidly decrease to about 20% if carcinomas was diagnosed in a late stage. Serous carcinoma, which make up 17% for all histotypes of ovarian cancer, are usually diagnosed as late stages. 51% at stage 3 and 29% at stage 4, being one of the most aggressive subtypes. In conclusions, I would like to thank the staff of 3 centers involved on development and research at once: Nizhny Novgorod Oncologist Center, Brukhin Oncologist Center, Moscow, Nizhny Novgorod Simashka Hospital. Typical borderline cirrhosis ovarian tumors, the weight 20 kilograms, size 4 centimeters. I removed this tumor 3 weeks ago. The patient has not been to a gynecologist for more than 5 years. She had in ORATS 5 MRI picture and assay 122 30 units. At the same time, the test for circulating DNA worked positivity. Intraoperativity malignant tumors has diagnosed in the optimal surgical volume of the operation was performed. Thank you very much.
Thank you very much, Dr. Sviatoslav.
Thank you.
Nice demonstration. Now I would like to invite Dr. Kevin Odiga from UK. His speech article is Improving Diagnostic Accuracy in Digital Pathology and Cancer Care by Integrating Quality Management System in Cellular Pathology Laboratories. Please, Dr. Kevin.
Yes, I believe everyone can hear me now. Okay, good morning. Sorry, I had a bit of technical difficulty earlier on. I'm just going to share my screen. Yes, so this morning I'm Dr. Kevin Odega, a specialist biomedical scientist, and I work with St. George's University of London. It's an NHS organization and a relatively old one. It's been established since 1733, and we are a regional laboratory where we provide services for the whole of Southwest London, We service about 1.3 million people yearly. And I will be talking this morning on improving cancer diagnostic accuracy in digital pathology techniques. For this presentation, I'm going to be using this outline. It will be pertinent that we understand what digital pathology is, and we also understand what quality management system is. And we now look at how we can integrate quality system management and digital pathology. And finally, we're going to be looking at the future directions for us. So, what is digital pathology? In a simple term, I'll refer to it as virtual microscopy. And it's a process where...
Dr. Kevin?
Yes.
Can
you
you
hear
share
me?
your screen?
Can you hear me, please?
No.
Oh.
We are not able to see your presentation.
Okay. 1 minute, please. Can you see my presentation now?
No.
Oh.
Otherwise, we will share your presentation.
Yes, I sent it over. I'm coming 1 minute.
Yeah.
Okay.
Next present.
There's someone else sharing. So I think the previous speaker is still sharing.
Our technical team is sharing your presentation. Kindly wait, Dr. Kevin.
Okay.
Dr. Kevin, kindly do next.
Okay. Can I reshare my presentation now?
Yeah.
It's telling me there's someone sharing already. So there's someone else sharing a presentation, so it's not allowing me to share my screen.
Yeah.
Can you see my presentation now?
No, not at all.
What's happening?
Here's your presentation now.
Yeah. Can you see my screen now?
No.
Okay, 1 minute.
Otherwise, technical team will help you.
Okay.
Yeah.
Is it working now?
Yeah. Now it's working.
Okay. All right, thank
Can I
you.
see your screen? Kindly proceed.
Okay, all right. So I believe you heard me earlier on, and I'll just continue from
Yeah.
where I stopped. Just one minute, please. Okay. So just as I said earlier on, digital pathology has to do with what we call virtual microscopy. And what it actually entails is that it entails capturing images and managing these images that have been captured, which can now be analyzed and interpreted for digital information. So it's a very important diagnostic tool. And the very good thing about it is that it allows for remote access, which means people, pathologists that are not on site can actually make diagnosis. And then there can also be collaboration for second opinions when necessary, and help in accuracy in cancer detection. Now, this is just a digital pathology workflow. In every laboratory process, there are three major stages. We have the pre-analytical, the analytical, and the post-analytical. Now, quality system management plays a very crucial role across these three areas. What you get at the end of the day, the results you get is as good as the samples you get. So for you to have a very good digital pathology platform, you must have ensured that quality system management has been put in place across these three major areas. The pre-analytical has to do with how we get our samples, how these samples are preserved, which is very key. The samples, if they stick to the world best practices and quality management guidelines in terms of sticking to ischemic time, making sure the samples are well preserved adequately and optimally, and also making sure that all the processes that the tissue has to go through, right from dissection, through tissue processing, through embedding, through microtomy, and finally sectioning and staining, are all done properly. If there is any mistake in all these areas, if there are any quality issues, the digital pathology platform will not be able to maximize and give you the best. So samples have to go through preparation, and then these samples, after being prepared, has to be captured. The whole slide scanners, there are a lot of array of them that are being deployed presently, can be used for this purpose. And these images are captured and viewed under the microscope using softwares where necessary. And these images are also stored. And also, there is a room for integration with health records of the patients, so that when the pathologist is looking at these images, he has all the clinical information of the patient. And these data can also be shared across a wide array of networks. And these are also integrated into the laboratory information management system, so that copies of results and copies of images can be sent across to all the necessary parties. The role of digital pathology in cancer diagnosis, just as I said earlier on, cannot be overemphasized. And there is need to integrate quality management system within digital pathology across the different workflows. The good thing is that digital pathology significantly improves diagnostic accuracy. It enables the pathologist to analyze very high resolution images with advanced software tools, as I said earlier on. And this helps in giving precise diagnosis and identification of cancer lesions. So just like every other system, there are pros and cons to digital pathology. And the pros include the fact that it improves diagnostic accuracy. It has been well established, and it facilitates remote collaboration. So a pathologist that is thousands of miles away from the center can also make diagnosis. And then it enhances workflow efficiency because these results can be sent across a wide area of network, and patients can easily get their results as soon as possible. It also supports standardized procedures, and it reduces human errors, and it enables better data management. Now, the cons include the fact that it is quite expensive, and it requires a lot of technical training, both from the biomedical scientists and the pathologists, and even the IT team that plays a very crucial role in managing the network. There are also concerns about data security. As we all know, the cyberspace is not very safe. Sometimes there is tendency for networks to be compromised. And another very important con is that it depends majorly on technology. So the digital pathology platform depends majorly on how good the technology, both the hardwares and the softwares are. So if you're using a whole slide scanner that is not very optimal, or that is not giving you very good resolution images and don't have the latest software, you might run into problems. And there's also challenges about integration. As we might have seen, digital pathology is a multidisciplinary, takes a multidisciplinary approach. There are different professionals from different backgrounds coming together to make this work. The biomedical scientist is there, the computer specialist are there, the IT specialist are there, the pathologist who makes the diagnosis are there, and a whole lot of other professionals, the health records staffs are there. And it also involves ongoing maintenance, which are also very expensive. So these are the challenges in digital pathology. The major challenge that we've noticed, like in my center, is data management. Just 2 months ago, we moved from a platform which we've been using for a while to a new platform. We signed a new contract with Leica. Before then, we were using a platform that is mainly was mainly run by Roche Diagnostics, where we use the Vantage system. Now we moved further to the Leica system, so we're using the Cerebral system and other sophisticated software. There's also difficulties in integration, and hence, just as I said, there has to be collaboration with different healthcare professionals, which is also a challenge. Everybody has to be on top notch when it comes to digital pathology. There might be interoperability issues, and then this might hinder seamless data exchange, as the case may be. Then quality assurance gaps. We all know that when it comes to quality management system, apart from the ISO and the CLIA regulated platforms, most regions have their individual or localized platforms which they adhere to, which might not be on the same level or the same standard like what we have here in the UK might be different from what you have in India or what you have in Dubai or what you have in back home in Africa. So there can be variations, and these variations is a challenge in the terms that it can affect how images are gotten and how they're processed and how they are interpreted. And this on the long run can impact on diagnostic accuracy. So I've said so much about quality management system. It's good that we take a look at what quality management system is. I will simply define it as coordinated activities that direct and control an organization. It directs and controls the workflow in the laboratory. And the 12 major essentials, as you can see on the screen, which play a very important role in quality management system. Now, it is important that all aspects of the laboratory are addressed in terms of quality assurance, and these are the things that constitute a quality management system. Now, so what role does quality management system play in cellular laboratories? First of all, it helps to standardize protocol implementation. Quality management system helps us to establish uniform protocols. It gives room for making sure that staffs of the laboratory follow the same procedures, which reduces variability and enhance reliability of diagnostics. And this will, in turn, give efficacy to results in cellular laboratories or cellular pathology laboratories, as the case may be. There is also regulatory compliance assurance, which is a very key role. We all know that quality management system is very robust, and it ensures that every organization adheres to regulatory standards. And these are done through different systemic documentation, regular audits, and on the long run, the patients are able to benefit from a very good and reliable, reproducible, and timely result, which helps the patients and give also credibilities to the laboratories and other stakeholders. Now, it's also data-driven continuous improvement. Quality management system provides organizations with data that can help them manage and utilize these data for different purposes, such as feedback mechanisms, and then also enables the laboratories to identify areas that needs improvement and also areas that have challenges, and these can now be addressed. Now, implementing quality management system is very essential. Just as I said earlier on, it allows the laboratory to issue accurate, reliable, and timely results. And it's very important that these results are reproducible, because we're actually addressing cancers, which are very, very key and very, very important. And these are things that you can't afford to make mistakes about. So the benefits include the standardization of the process. It helps manage risk, and because there is a systemic risk assessment, corrective actions can be implemented where needed, and then it allows the lab to proactively identify and mitigate potential hazards, which might be to the patient or even to the workers that are carrying out the analysis. And in turn, it increases stakeholder confidence. Most people want to be very sure that what they are getting at the end of the day is what it should be. And this is one very important benefit of quality management system. There are a lot of case studies that have shown the efficacy of improved diagnostic outcomes. I just picked one or two across board, and these have helped streamline workflow efficiency and also enhance compliance and accreditation. Most of the regional accreditations and international accreditations and quality management system actually helps to address all these and make sure that laboratories are properly accredited to function. So how do we integrate quality management system with digital pathology? The different strategies, and one very important strategy is that by bringing in quality management system, we can actually standardize protocol development. Now, in implementing quality management system, it's supposed to be a stepwise thing. It's not something you just wake up one morning and start. It's done in phases, and these phases address different areas and aspects of the laboratory. So there is need to bring it into to standardized protocol, which we use in accurate images for analysis, and even in reporting within the digital pathology. This actually helps to maintain consistency and reliability. And on the long run, it enhances the efficacy of and accuracy of the results that we get. Another very key importance is that it's a foundation for diagnostic excellence. There is room for continuous quality improvement, and which helps to establish a systemic approach to enhance diagnostic processes. Now, these diagnostic processes are data-driven and then ultimately leading to better patient outcome and increased trust in diagnostic services. So, we'll be looking at other areas. There is need for digital skill development. There is also need for quality assurance training, and there's also need for mentorship programs. Digital skills addresses the importance of training for the workers within the laboratory, and these also include proficiency in digital imaging softwares and also data analysis tools, which are a lot of them. But there are some very key things when it comes to digital pathology, which professionals in this aspect has to be very, very cognizant with. Some of them include the use of artificial intelligence in diagnosis. And in using artificial intelligence, it will enable the digital pathology. Can you hear me, please? Hello? Hello? Okay. Yeah. Am I still on?
Yeah.
Oh, okay, good. So
Yes.
the impact of quality management system and diagnostic accuracy, it will help reduce a lot of errors, and it will help standardize the process and also include continuous improvement framework. So there are some tools, just as I mentioned, that are very key in utilizing quality system management and quality assurance in advanced imaging and digital pathology. This includes infographic tools, and also includes the use of deep learning to help, which employs the use of machines in machine models in actually making diagnosis and making very important diagnosis at the end of the day. So how do we overcome the barriers in integrating quality management system? It is important that we address technological challenges, such as compatibility in softwares and hardware solutions, and also implement a comprehensive training program for laboratory staffs, which will help to address the resistance to change. And in conclusion, there is the emerging trends in digital pathology. We have the integration of AI technologies, which will help to the pathologists to understand and interpret images using very sophisticated tools such as the computer vision and the graphic processing unit and the computer aided diagnosis. So these are artificial neural networks that can be used to enhance diagnosis alongside with the expertise, pathological expertise of the pathologist. There is also real-time data analytics, which leverages on the real-time data analysis within the quality management systems. This enables immediate feedback on diagnostic processes, thereby enabling laboratories to quickly identify and rectify discrepancies in cases where there are discrepancies and improving overall accuracy. There is also telepathology advancement, which is not very new in pathology. It facilitates a process where you can remotely consult and seek for second opinions and also create a broadening access to expert evaluation. So we can have the pathologists from Dubai or India or Russia also looking at the same case or the United States at the same time and then making their general inputs on the long run. This is very important because of the complicated cases, in cases of complicated cases, as the case may be. These are different tools that can be implemented in quality management systems when you're integrating them into digital pathology. You have to implement a robust documentation practice. You have to implement a comprehensive quality management system. You have to engage interdisciplinary collaboration. You have to also utilize performance metrics for improvements. Then there's also very important need to invest in staff training and utilize advanced technologies. These are my recommendations for different cellular pathology laboratories. In conclusion, integrating quality management system in cellular pathology laboratories significantly enhances the accuracy of cancer diagnostics. We all know that the world best practice involves a patient-centric quality assessment, where the focus is on the patient, on getting reliable, timely, and reproducible results. So research should also explore methodologies for integrating patient-reported outcomes into the framework and allow laboratories to align quality improvement initiatives with patient experiences and expectations, ultimately enhancing service delivery. Thank you very much for your time, and thank you so much. And I want to thank my organization for giving me room to take most of the pictures that you saw from our laboratory. Thank you.
Very nice demonstration, Dr. Kevin. Any questions from audience? Any questions? I think there is no question. Nice demonstration, Dr. Kevin.
Thank you very much.
You demonstrated very precisely. Thank you very much. Yeah. Now I would like to invite our new speaker, Dr. Nadia Sam from Algeria. Her topic of talk is
Hello everyone. Hello.
Hello.
Do you hear me?
Yeah. You are audible.
Okay, thank you. Thank you. I'm very happy to attend at this conference. Alors, sorry. Sorry. I will participate with an intervention on language deficits in amyotrophic lateral sclerosis. The scientific literature agrees that amyotrophic lateral sclerosis, also called Lou Gehrig's or Charcot disease or la maladie de Charcot, is a rare central nervous system pathology affecting both the upper and lower motor neurons. It means that this disease is a progressive neurodegenerative disorder which touch neuron disease. In addition, cognitive and or behavior changes are estimated to occur up to 50% of patients who suffer by this pathology. Sorry. According to CISLIS and all 2022 language impairments are increasingly recognized in this pathology, supporting the view of ALS is a multi-system disorder impacting cognitive and motor functions. However, the language disorders are heterogeneous. Furthermore, to our knowledge, no study has been done on language impairments in ALS in Algeria. For that, I was very interested to conduct this research. Despite the common belief that this pathology often manifests between the ages of 55 and 75, it appears earlier. Although there have been limited LS researchers in Algeria, then there are no national statistics available, but in some regions or some hospitals published some statistics as Blida and Tlemcen. This study aims to describe the language disorder occurring by ALS. Sorry, my English is not very good. I try to speak as well as I can in patients in Algeria. In order to achieve our goal, we adopted the clinical method that allows us an exhaustive description of language disorder in this pathology. Participants, for many reasons, particularly healthy ones, I could only examine 3 cases that characteristics are described in this table. The first one is a female aged 30 years, and the second one 39. The last one is 42 years old. In addition to muscle weakness, the first patient suffers from vocal cord paralysis, and I examined them in different periods. Here, the first one, 9 months after the diagnosis, and the second one, 12 months after the diagnosis, and the last one, 14 months. To assess language function, we employ the following tests. A spontaneous language test, it includes several inquiries concerning the patient's daily activities. The second one it's the evaluation of verbal evocation. It's a test I developed in 2013, and it's now in revision. And it consists of 5 subtests, including naming, verbal evocation, category and formal evocation, and fluency subtests, narrative evaluation through a natural stories test developed by Sam and my colleagues and revised in 2022 for only the revision was only for Arabic Algerian spoken. Because the test touched also French spoken and Amazigh spoken. Both the two last tests evaluate other cognitive functions such as short memory term, and the third one assesses also auditive and visual selective attention. Results and discussion. The first case we observed in this case a swallowing disorders, chewing disorder deficits, absence of comprehension impairment, a complete loss of the voice that compelled the patient to communicate only with by writing, and absence the unusual events in sorry deficits were identified. In a second case, we noted the phonetic problems caused by the breathing difficulties, a discrete word naming deficit in relation with production. In the output, the patient couldn't produce the name, has difficulties it's in relation with the muscular weakness. And we noted an absence of verb category and formal evocation deficit, verbal fluency impairment, the difficulty in comprehension narrative, especially during the second phase, which consists of telling the story a second time using visual support. In the first time, we tell the story and we ask to the patient to repeat without support, because the test is la bande dessinée. In the test, there are three phases, and we have visual support. But in the second phase, the patient thought that it was another story, not the same story, and then he didn't understand all the story, and he couldn't identify the unusual events, and we noted syntactic disorders. And in the second case, we noted also phonetic, phonologic, and syntactic deficits, naming word deficits, which manifest in the missing word, relied with phonological and semantic impairments, absence of verb evocation deficits, and here we noted a preservation of the evocation of verbs in relation to the evocation, contrary to the evocation words. What we observe that in aphasia and Alzheimer disease. The evocation is of the verb is easy if we compare it with naming or naming test or naming evocation. A discrete category and formal evocation deficit, especially in the second phase, which implies verbal short memory disorder. Verbal fluency impairment that then we observed in the two last cases, verbal fluency. The patient speaks very slowly, very slowly, and they tell only few words in a minute, 3 or 4 words in a minute. Comprehension deficits in narrative, and inability to identify the unusual events in each story of the test, what suggests a deficit of the mind, the theory of the mind. In conclusion, even if the study includes a very small group, group, it reveals the presence of several language deficits involving phonetic, semantic, syntactic, and pragmatic impairments in amyotrophic lateral sclerosis. In conclusion, to accurately describe the language disorders that could be connected to cognitive impairment, more included are the linguistic levels is necessary. And thank you for attention.
Thank you very much, Dr. Nadia Sam. Nice demonstration. Any questions from audience? Any questions? Okay, I think there is no questions from audience. Thank you very much, Dr. Nadia. Now we are
Thank you.
Now we are closing day 2 session. Thank you very much for our esteemed speakers, in person or online speakers. We are winding the session, day 2 session, and we will start day 3 tomorrow at 9:30 a.m. as per Dubai time zone. So kindly get ready tomorrow as per 9:30 a.m. according to Dubai time zone. Thank you. Thank you very much.